Good morning, everybody, and welcome. We're just admitting our last few folks in the waiting room, and we'll begin in just one moment. So thrilled today to have the opportunity to see all of you and in the virtual world once again, and to be able to today celebrate something that I think has become a pillar for our school since we began in 2012. We were delighted upon the creation of the school to have the opportunity to actually build out an endowed lectureship through a generous gift from Daiichi Sankyo to their then outgoing CEO, Joseph Pieroni. And so in our first year in existence, we created an endowed lecture where we would invite leaders from across the industry to be able to speak about the exciting changes and the exciting and emerging pathways for students and for opportunities for growth of the profession of pharmacy into new and exciting ventures. And in so doing, we have welcomed over the years a number of very, I think, well viewed and well-versed and well-rounded individuals who really are leading this charge across pharmaceutical industry, across managed care, across medical devices and other industries. And today, I think we're excited to be able to welcome another person in that history and that pattern of emerging leaders in emerging markets. And so we're going to hear today from Karthik Ganesh. Before I introduce him and before I give you a brief bio to tell you a little bit about him and about EmpiRx, the company that he represents as the CEO, just a couple of housekeeping rules or logistics. We would ask that for those who have questions, we hope that there'll be some time in the end for a Q&A. And we would ask that probably the easiest thing to navigate that in the midst of 200 plus people in the room would be to be able to do that in a way where you put your questions in the chat box. And I will monitor them towards the end to see what questions are there and to be able to try and pick some out for Q&A. Additionally, we are recording today's lecture, and so we hope to be able to make that available to you afterward, and with the opportunity to learn and listen again, should you have anything that you want to hear again. And we'll also make that available to the pharmacy and health sciences community for folks who could not be here today. So without further ado, I'm going to just provide a brief introductory bio on our speaker today and tell you a little bit about him and a little bit about his background, and then open the floor up to him where he will speak to us today on reimagining healthcare and pharmacy benefits. And so first, a little bit about our speaker. Karthik Ganesh is the CEO of EmpiRx Health, the industry's only value-based pharmacy benefits manager with a clinically focused and tech-enabled approach to bending the prescription cost curve. Karthik has built EmpiRx Health into an Inc. 1000 company and a certified great place to work while transforming it into a high-growth and high-innovation engine. He's a senior healthcare executive with a solid track record of comprehensively growing, transforming, and maximizing value at tech-enabled health service companies while driving dramatic before and after results across all facets of the organization, including growth and retention, financials, business operations, technology, and culture. As the Executive Vice President and Chief Operating Officer of QualCare, he transformed a provider-sponsored third-party administrator into a tech-enabled health services powerhouse that specialized in powering and operating health plans, value-based shared savings models, ACOs, and joint payer-provider strategies until they were acquired by Cigna. Prior to EmpiRx Health, he was the founding operations leader of CareAllies, a Cigna subsidiary focused on value-based care enablement, and his background includes leadership roles at Aetna and Express Scripts, senior management consulting roles at Deloitte and at Ernst & Young. He is recognized as a thought leader on healthcare, leadership, and resilience, and is a published author who has been featured in leading industry journals. So without further ado, it is my great pleasure to introduce today's annual Pieroni Lecture speaker, Karthik Ganesh.
Thanks, Michael. And thank you to all of the participants on this lecture for the opportunity to present to you today. Before I jump into the material here, right, I wanted to just reflect a little bit on this past year. We're sitting 12 months, 13 months into what is arguably the most severe public health crisis in our lifetimes, at least our lifetimes thus far, right? And and I say arguably because it's probably a couple of other things that happened along the way, but arguably one of the most severe public health crises we've seen. So when we think about the last 12, 13 months, the one word that probably continues to hit us is adversity. And it continues, right? I mean, we're still in the midst of the thing. But here's the beauty of it, right? And this is what gets me excited, if you will. Whether it's in our personal lives, our professional lives, whatever the scenario might be, adversity is virtually always a precursor to opportunity. And that opportunity is what gets me really excited about being in healthcare right now. Because we have an opportunity right now, and we're going to see this, I believe, where healthcare innovation is going to is going to take off like never before. We are hopefully going to see a reimagining of healthcare in proportions that we really haven't seen. There's been too much lack of inertia over the last couple of decades, and I feel COVID has been such an incredibly strong wake up call that it is going to force us and challenge us to reimagine healthcare. It is going to challenge employers to think differently about what it means for them to provide value to their employees in terms of healthcare benefits. And I truly believe that employers are going to be the ones who will power this next reimagining of healthcare. 82% of healthcare costs in this country are picked up by employers. And one would hope that employers will now step up and drive essentially the next gen of healthcare in this country. And that's what gets me really, really excited. And when I think about you as students, um, pharmacy, health sciences, being on the ground floor of what could be the most significant change in healthcare in our generation, I'm excited to be in your shoes and really all of the opportunities that are going to show up for you as you continue to blaze trails within the healthcare arena. So with that, here's how we're going to approach today's conversation. So I think it's important, right, to almost lay the stage for what adversity looks like before we can pivot towards opportunity. So we're going to talk about the challenge in healthcare at large and pharmacy spend. We're going to talk about the impact of COVID-19, and we will also talk about what hasn't worked. What hasn't worked, not just from the standpoint of public health and COVID here and now, but what hasn't worked over the last 15 or 20 years that has just made COVID seem even more impactful than ever before. And we will take a very pharmacy oriented lens as we talk about what hasn't worked. And then we'll talk about what the answer is, and then we'll close it out with a reimagining of healthcare. The challenge first, front and center, right? Healthcare spend is projected to grow faster than the economy in the next 10 years. Just think about that for a second. Um, there used to be a time when at General Motors, at GM, the joke was that it cost more in healthcare benefits to get a Chevy Cavalier off the assembly line than the salaries that went into and the build out cost of building that car. Healthcare spend continues to skyrocket on our watch. And then when you look at that overall healthcare spend bubble, right, $3.2 trillion, what CMS, the Centers for Medicaid and Medicare, continue to come back and tell us is that a very significant percentage of that, 25%, is waste. I mean, waste could be a multitude of different things, right? I mean, as we think about it from a pharmacy spend standpoint, and we're going to talk about that in just a little bit, but waste could be as simple as continuing to dispense medications that are brand medications. So for example, right, I mean, we continue to see this with a number of employers who come to EmpiRx looking for pharmacy benefits. Nexium, which is, for, essentially for heartburn, right? Nexium came off patent, I want to say in 2006, if I'm not mistaken. And we still see Nexium show up, even though you've got over-the-counter alternatives that are markedly cheaper than a Nexium showing up. So we continue to see, and this is not just in pharmacy spend, on the medical side as well, we continue to see waste in the healthcare system just take on some very significant proportions along the way. And that's a huge factor in driving healthcare spend. Pharmacy spend is now 25% of the total plan spend. And this was at the end of 2019. I would think 2020, with medical spend having dropped a little bit, and utilization is expected to pick up again in 2021. But as we saw folks, fewer folks showing up at the hospital or showing up at the doctor's office in the midst of all things COVID last year, we would think pharmacy spend is now an even bigger percentage. But 25% of what an employer spends on their employees, on their total plan spend, is now pharmacy related. And then here's a really interesting visual, right? You just look at pharmacy or prescription drug expenditures per capita. Just look at the way that thing continues to grow. There was an article I read last week where in 2020, pharmacy spend, outpatient prescription drug spend, right? So not medications prescribed and dispensed inside of a hospital setting. Outpatient prescription drug spend grew at a faster rate than healthcare spend at large. It also grew at a faster rate than we spent more on outpatient pharmacy spend last year than inpatient costs. I mean, you're looking at this pharmacy spend balloon just keeps growing and growing and growing and takes on an oversized percentage of the total healthcare spend. Americans spend $1,200 in prescription drugs each year. Specialty drugs, which are less than 2% of the claims, now account for 50% of the total drug spend. Specialty inflation, which I haven't called out here, specialty drug inflation is anywhere from 18 to 20% year over year. And the average cost of a specialty medication is $4,500 a month. Just some very significant pharmacy-related costs as it pertains to the broader healthcare spend bubble, if you will. So now let's talk about COVID-19. And these are very stark numbers, and they're all interrelated. And I want to talk to you about what that means, especially as you think about it from the lens of pharmacy and health sciences. First, substance abuse, just broadly, right? COVID-19 is arguably a mental health tsunami like we've never seen it before, right? Whether it's people just stressing out about their rent, people stressing out about being able to, just fundamental affordability, whether it's, folks working from home or doing things from home, students from home who are not able to have that social interaction with their friends and peers, just cabin fever, right? The mental health implications of COVID-19, the ripple effect of that is going to be felt for the next 10, 15 years. But just look at some of these stark numbers here. Substance abuse, 40% of Americans are now grappling with mental health or drug-related problems. And look at the number of the states that have reported a significant spike in opioid-related deaths. Even from a pharmacy benefit management standpoint, I will tell you, so most states started shutting down, if you will, in the March timeframe last year. April, May, and June, we saw a 40% spike in antidepressant prescriptions showing up in our claims. I mean, so it just gives you that perspective. Pharmacy deserts. We talk about access to care, right? I mean, the health policy, if you look at health policy over the years, right? And every single president or every single administration that has really said we're going to go after healthcare big time have grappled with the exact same dichotomy: cost and access. Even when we think about Obamacare back in 2008, or 2009 when he was trying to push it out. It started off as one thing, it ended up as another thing. Access is a challenge. And this notion of pharmacy deserts, especially as you look at all things COVID right now, um, smaller pharmacies, independent pharmacies just can't afford, have not been able to afford, or have not been able to stay open in the midst of everything going on right now without the kind of foot traffic that they were used to. 177 counties don't have pharmacies. That's about 635,000 people who are going to drive extremely long distances to get a COVID vaccine, right? So they're calling them pharmacy deserts because the access to a pharmacy close at hand has started getting diluted over this past year. A 20% decline in drugstores in New York City since 2016. So we talk about access to care, the notion of pharmacy deserts, and I'm going to talk to you about how all of this starts looking like Medicaid in a little bit, because this is what we see in Medicaid. Suicide rates, suicidal ideation, right? People contemplating and thinking about ways in which they would end their life. 1.6x in March and 1.45x higher in March and July than in 2019. 1 in 4 adults have thought about killing themselves in the past 30 days. You talk about, again, mental health is significant. Mental health very clearly transcends over time to physical health, and as a result, pharmacy implications, which is why I'm calling out some of these things. Depression, greater than 90% of employees have reported some level of anxiety. 37% of adults said they felt hopeless. Health systems under pressure, more than 36 hospitals entering bankruptcy. There was a really interesting stat I saw, interesting, not in a good way. 44% of physicians polled experience a very high level of burnout as a result of this past year. They've been on the front lines, right? Um, and then health equity. This has been a challenge across the world, especially in the United States, forever. And it has clearly come to light as a part of COVID. African Americans have died at a much faster rate than white people. LGBTQ employees, 2x more likely to suffer from severe stress or depression. Some very, very, very stark numbers. And one would think, well, we're seeing a lot of these for the first time. That's not true. This is what we continue to witness in Medicaid. So for those of you who are unfamiliar with Medicaid, folks who are below the poverty limit, below the federal poverty limit, and or have some very significant health condition, like end-stage renal disease, etc. You've also got the fastest growing percentage of the fastest growing part of healthcare spend in this country are dual eligibles, folks who are eligible for both Medicare and Medicaid. And what we are seeing with all of these things that I've called out as being COVID related are things that we have seen in Medicaid. Substance abuse has a very high propensity in Medicaid. Pharmacy deserts, the notion of access to care. So CMS, when you've got a new Medicaid plan or a Medicare plan that has to now satisfy low income populations, access to care, the Medicare or Medicaid benefit has to include transportation. Because when people are fundamentally making pocketbook decisions, do I buy my groceries this week or do I refill my Medicaid prescription? Do I pay my rent this week or this month or do I refill my prescription? Do I see, I mean, the examples just keep going, right? Can I afford to have healthy food on the table for my kids, or do I need to have the money to be able to take them to a doctor in case they fell sick? Fundamental health wealth decisions that folks in Medicaid have been forced to make over the years. And when you look at Medicaid innovation in the country, if you ask Medicaid innovators, they will tell you one of the biggest things that they struggle with is getting folks to show up at the healthcare facility. So access to care becomes an extremely important construct. Suicide, depression, all of these are constructs. Pharmaceutical drugs prescribed, or prescription drugs prescribed for mental health conditions are one of the largest contributors of Medicaid spend in the country. Health equity issues have been a struggle for, for the last 30, 40 years from a Medicaid standpoint. So when you think about it, if you take a step back and you look at this very dispassionately, the entire country, or a big chunk of this country, is going to feel like Medicaid. Very tough message to think about, right, when you contemplate that. But on the flip side, what I would tell you is all of the bulk of the thinking, the bulk of the innovation, the bulk of the let's figure out a different way to skin this cat. A lot of that happens on the Medicaid side of the house, which is what excites me about where we are as a country right now. Again, I completely doesn't take away from all the challenges we have. But again, a headwind is a headwind only if you look at it. If you turn your back to a headwind, that same headwind becomes a tailwind, right? Adversity breeds opportunity. We are sitting on the precipice of healthcare innovation like we've never seen it before. And if there's one thing to be said about us as a country, when the going gets tough, we really get going as a country. And I am so excited about the fact that uh, healthcare innovation for the next 10, 15, 20 years is going to be in proportions that we've never seen it before. So that's the pivot, if you will. Very exciting time to be in healthcare. So now you take a step back and you look at it from a pharmacy benefit standpoint. When Michael introduced EmpiRx Health, he talked about a value-based PBM. I'm not going to talk to you about EmpiRx Health, but the notion of value are what I want to talk about in the next two slides, because the healthcare policy dichotomy has been, well, is it about cost or is it about access? Can you offer more access to people who need care while still reducing the cost of healthcare? And health insurance companies, healthcare policy has said no. But that is a fake dichotomy, and I'm going to tell you why it's a fake dichotomy. Quite frankly, up front, we talked about the fact that 25% of all healthcare spend is waste. Just from a pure waste management standpoint, the dichotomy of access versus cost is fake. And what I want to share with you, and I've written exhaustively about this, is my hope is that people will pivot, employers will pivot and stop thinking about cost versus access and start thinking in terms of value. But let's talk about what hasn't worked in pharmacy benefits. First, financial misalignment. And you know what, while we go through this, right, I want to share with you this commercial that you probably remember from maybe I think it was about 2 or 3 years ago. And I want to say it was a Charles Schwab commercial, but I could be incorrect in that one. But you had a dad and his son sitting across from each other over a meal. And the dad says, well, son, you've graduated, congratulations, and you've got a job. And the son says, well, thank you. He says, have you thought about investing? And the son says, I have, and I'm doing some research about how I want to go about it. And the dad says, well, you know what? I've got a broker that I'd like to introduce you to. And the son says, well, I have a question for you as well. If your broker does not make you the money that he or she committed to, do you get to pay? Does the broker pay back those commissions? And the dad looks at him and says, oh, it's really not how the world works. And the son responds and says, well, it's a new world, Dad. When employers' costs keep going up and the PBM, or the pharmacy benefit manager, keeps making money, it is a misaligned model. And that is something that we see across healthcare. When you're probably learning about this as a part of your degree as well, but value-based healthcare has taken on a life of its own in this country, and for the right reasons. Value-based healthcare has been about the fact that there is a fundamental misalignment. Value has to be gauged from the standpoint of the vendor's income has to depend on your outcome. You can't keep doing poorly and expect the vendor and allow the vendor to make money. It's misaligned. So let's talk about this for a second. The pharmacy benefit industry has continued to thrive on volume and arbitrage. And I'm going to say pharmacy benefit management industry, but it's really much bigger than PBMs. It's healthcare at large. Healthcare has been about who's got the most volume, who's got the most membership, and how can they go and buy in bulk. How can they buy prescription drugs in bulk? How can they buy services in bulk? How can they arm twist physicians to give them better rates? How can they arm twist manufacturers to give them better rates? Healthcare has become like retail. And that doesn't make sense. The way you service healthcare cannot be the same, or the way you buy healthcare benefits cannot be the same as the way you buy a t-shirt. It doesn't make any sense. The PBM revenue has continued to increase despite volume, and with volume going up. And here's the thing, right? Buying more drugs, as much as we're all in the pharmacy space together, right? You're going through your pharmacy education right now. I'm in pharmacy benefits, but we all intuitively, as it pertains to our family members, if our family members were to be prescribed drugs, we understand that more drugs does not equate to better healthcare. It doesn't equate to better healthcare. It doesn't even equate to a healthy wallet, right? And this dichotomy that I talked about, choosing between cost and access. Now, let me tell you the clinical aspect of it. You're training to be clinicians. So member care and cost savings opportunities go unidentified when you look at things in a condition basis. I want to talk about this for a second, right? For the last 25, 30, maybe even longer than that, what has been a trend or a continual thought process in healthcare is this notion of therapies based on conditions. And it has been very easy for healthcare to completely pivot off of the way pharma thinks about solutions. Well, if you've got diabetes, I'm going to manufacture, or I'm going to do the research and manufacture a drug for diabetes. If you're sitting at your desk and your leg keeps moving, maybe you've got restless leg syndrome, and I'm going to go and do research and get a drug for restless leg syndrome. This notion of condition orientation has not worked. And we have continued to see this because over the last 20 or 25 years, you've continued to see healthcare service companies, pharmacy benefit managers, health insurers come to the table with these condition-oriented programs. They'd say, well, we're going to come to the table with a diabetes clinical program, or a clinical program for CHF, congestive heart failure, or a clinical program for COPD. What has been lost in the scheme of things is that you can't have a one size fits all. Just because person A is diabetic does not mean person A should be treated the exact same way as person B. And COVID, we talked about health equity and a disproportionate percentage of people in the Black community getting hammered by COVID as an example. By virtue of taking this condition orientation to clinical or care management at large, a lot of critical red flags have been ignored over the years. SDOH is social determinants of health, socioeconomic challenges that drive healthcare, right? We talked about making fundamental pocketbook decisions. Can I afford to buy my groceries this week, or do I go and refill a prescription? That's a fundamental socioeconomic decision that is going to drive healthcare. Underserved communities, racial stratification that tells you, again, African Americans have a higher propensity of getting COVID than Caucasians. Health equity is not a COVID, as much as we're talking about it right now. Health equity is not a COVID-driven phenomenon. Health equity challenges have been a challenge for, as long as healthcare has been at the forefront of this country, quite frankly, the world at large. What condition orientation also does is you zero in on the current risk. You focus on, well, this person's a diabetic right now. I'm going to focus on this person's diabetes. But what it doesn't account for are comorbidities. A person might be a borderline diabetic, but a person, or might not even be diabetic right now, but let's say the person is morbidly obese. So let's say they're clinically obese, right? Clinically obese. WHO, the World Health Organization, says that 1 in 3 Americans is clinically obese. Okay. Clinical obesity is a precursor to diabetes. Clinical obesity is a precursor to a, a higher cholesterol condition. Clinical obesity is a precursor to a multitude of different things. But if you zero in and say, well, I'm going to treat this person for their diabetes, you are essentially ignoring all of the other comorbidities that could be underlying that person's condition. Yet, as an industry, we have continued over the last 20, 25 years to zero in on condition orientation. And that has been a flaw. And the reason we think it's a flaw is because it hasn't controlled healthcare costs. It's not like we've become healthier as a country. We have not. Yet we keep doing the exact same thing. You talk about Einstein's perspective on insanity, right? Doing the same thing over and over and over again and expecting a different outcome. But here's the thing. We have seen in Medicaid, again, coming back to the Medicaid example or construct, we have seen in Medicaid when managed Medicaid plans think differently think in terms of risk, think in terms of population risk versus thinking in terms of condition orientation, they are able to come up with a very different set of solutions to improve the healthcare of the individuals, and really break through this artificial dichotomy of cost and access or health and wealth, right? And so let's look at what the answer is. So IHI is the Institute for Healthcare Improvement, and IHI, when they talked about healthcare quality, they rolled out this construct called the triple aim, and triple aim is um, continues to be the standard of care, the standard of quality, if you will, for health systems, hospitals, health systems, etc., across the country. And I'm going to talk about the triple aim, but while the IHI didn't call it out, the extension of the triple aim is the quadruple aim, and I'm going to talk about that in just a second here. All right, so the first is reducing per capita costs, creating a pay for performance model. So pay for performance in its most fundamental form, right? Let's say you had an employee let's say you went out there looking for a job, right, on the heels of your education. And let's say you're incredibly self-aware, you're very confident, and you know what you bring to the table. So let's say that prospective employee goes for a job interview, and he or she tells the HR person, when you're putting my offer letter together, don't give me a base salary. Give me all of my compensation based on my exceeding your expectations. Because I am so confident that I am going to exceed your expectations that pay me only for performance. Don't pay me because you have to pay me. I will tell you this, anyone who goes and says that in an HR interview, I'd be shocked if the HR person didn't at least take a step back and say, whoa, this is a very different kind of conversation. But we have seen pay for performance, when people understand that they have to move the needle to be paid, when income depends on outcomes, it improves per capita cost of healthcare. We have seen pay for performance deployed in Medicare. We have seen pay for performance deployed in Medicaid with some very solid results coming out of it, right? So that is the first aim in the triple aim. The second aim is population health, improving the health of the population. And this is where, versus having one size fits all solutions, looking at a population, whether it's an employer's population or whether it's a societal population, looking at populations and tailoring strategies to the population versus saying, well, you've seen one diabetic, you've seen them all. No, a diabetic in Madison, New Jersey is very different from a diabetic in Dubuque, Iowa is very different from a diabetic in Sacramento, California. There's a whole host of other things going on based on the socioeconomic profiles of those regions and a multitude of other things. We talked about it, right? Comorbidities, so on and so forth. Moving away from one size fits all clinical constructs and understanding that you have to create clinical strategies tailored to caring for populations. And then take that population and tailor it down to the individual within that population. Personalized medicine. EmpiRx, we just announced a huge partnership with the Mayo Clinic to really take population health and then take it down to the individual person. You talk about personalized medicine, there's about 200 medications that are not genetically, that are not suitable based on a person's genetic makeup. You want to know that. You want to be able to care for that person, those people who have been prescribed those prescriptions very differently. You can't afford to have a one size fits all as it pertains to them. And then member satisfaction, patient satisfaction, customer satisfaction at large, enhancing the experience of care for patients, right? Greater access, lower costs, a fantastic service experience. And then, quite frankly, employers should demand the exact same thing for themselves as well. Again, employers bear 82% of the healthcare cost burden in this country. Employers should demand lower costs and fantastic service. It's not a dichotomy. No one should tell you, well, you're going to, if you want a better price point, well, your service is just going to stink. That's not acceptable. That's the triple aim. And then you get to the quadruple aim, right? When you're out there looking for a job, or when you're looking for the next step in your professional journey, and if you were to ask the HR person, well, what is your culture like? How important is the satisfaction of your employees to, how do you gauge the satisfaction of your employees vis-a-vis your performance as a company? How important are your employees to you as a company? Satisfied employees equal satisfied customers, right? So the first three things with a triple aim, and staff satisfaction is the quadruple aim. And if you now think about it in a healthcare setting, right? You think about it in a hospital setting, pay for performance, which we talked about, then tailoring clinical strategies to populations, patient satisfaction, and then satisfaction of the hospitalists, the doctors, the pharmacists, et cetera, who work in the hospital setting. That's the quadruple aim. That, from a healthcare quality standpoint, becomes almost a prototype, if you will, for a chassis that could be the foundation of rebuilding healthcare in the country. And that's what is so incredibly exciting about where we are right now, which we talk about. So this is where the time comes to reimagine healthcare, right? It's forcing us to break down longstanding barriers, and this is the time for us to take a step back and look at a future that is markedly different from the past. Not the time for us to spend. It is not. While it's helpful to look in the rearview mirror, the road ahead is extremely important. Employers must demand value. We talked about those. The quadruple aim is about value. It's about alignment. Second, accelerating and embracing the fact that pharmacists play an invaluable role in the broader healthcare system. Again, pharmacy spend is growing at 25%. It's at 25% and growing at the fastest pace, which means you as pharmacists should become so much more important in the broader healthcare equation versus sitting in the back office of a retail pharmacy. How does the pharmacist become core to the patient's health or the patient's care team, right? The pharmacist should be consistently alongside the physician for any and all healthcare discussions as it pertains to the patient. And then resetting the pharmacy's role at the forefront of healthcare. We go into the pharmacy, there's a reason why we go into a CVS as an example, no disrespect. I shop at CVS all the time. And I think they're doing a remarkable job in terms of all things COVID right now. But there's a reason why the pharmacy is sitting at the back of the store, right? The reason the pharmacy is sitting at the back of the store is because they want you to walk through the store and shop for all these other things. Let's say you've got little kids. They want you to buy the 50 pack of diapers on the way to going and picking up your medication at the back of the store. Resetting the pharmacy's role. The pharmacist in that pharmacy should be in the business of delivering care and should be core, quite frankly, not just in the business of, but should be allowed to perform at the top of their license. The pharmacist continues to be one of the most trusted advisors to patients across the country. It is time to put them squarely in the midst of all things healthcare. And I'm excited about the fact that we're going to I'm hoping we start thinking on those lines as a country now. We've been evolving towards it. but now's the time for us to make some hardcore changes. So this is what I want to leave you with today, right? As you go through, as you wrap up, as you finish off your degree and you go on to being amazing clinicians or healthcare professionals, think big. Don't the traditional stereotypes don't work anymore, right? Think big and want bigger. You are going to be on the ground floor of the reimagining of healthcare in this country. Embrace that, because it is the country is going to need every ounce of the talent that you bring to the table to change healthcare, and you can absolutely change healthcare. And that's what gets me super excited about being in healthcare and this conversation today. Thank you. We'll open it up to Michael and questions. So I'm hopefully going to get to see some of you folks as well.
Thank you so much. I hope everybody is as encouraged as I am in terms of the opportunities for the future. I think we talk all the time about exactly that pharmacists practicing at the top of their license have an impact on patients, have an impact on cost, have an impact on every aspect of healthcare. And I think this was a wonderful opportunity to hear that resonated in sort of living proof. So I see that the first question on the table here from one of our faculty, actually, have you had an opportunity to speak to government legislators, and what is their response in terms of this outlook?
We have talked with local government, and what we continue to see, interestingly enough, is the perspective is that the change in healthcare is going to evolve from a change in buying patterns. I mean, it's as simple as that. We could have conversations with local and other government officials all day long, but unless they're all elected officials, right? Unless people who are fundamentally paying for healthcare change the way they think about healthcare, we're going to see more of the same. And that's where it is very, very exciting. When you see, I will tell you, I'll give you a very simple example. I listened to Michael's presentation. I think it was last week around COVID before and where we are right now. And a big part of the push last fall was, so about 40% of the country gets a flu vaccine today, right? And year over year, as we see claims coming through our system, we realize we probably see about 40%, maybe less, of folks going in and we see a claim for a flu vaccine. The push from employers to their employees fourth quarter of last year to go and get the flu vaccine completely changed the dynamic, because employers said very simply, this is not the time for you to show up at the hospital. Go get the flu vaccine. And we saw that 40%, the 35-40% number just ballooned to about 75%. 75% of people in our membership went and got the flu vaccine last fall. So the change is going to come from employers more so than anywhere else.
Thank you. Sounds good. Another question in terms of the came directly to me regarding specialty pharmacy and the specialty pharmacy spend and that trend in difference. And the question is essentially, how do you see the difference in pharmacy evolving to become much higher volume and specialty in terms of the cost and in terms of the impact of the things that you described?
So specialty pharmacy is so critical, right? Because you look at all of the innovation, it is going to drive specialty pharmacy spend. So what really needs to continue to happen is this is where the innovation examples and the innovation starts getting interesting. How do you keep allowing for that burgeoning of specialty pharmacy utilization while still figuring out ways to control the spend? And we see that. I mean, even in our book, I will tell you, we've seen, we brought on some clients at for 1/1/20 that had just obscenely high specialty pharmacy spend, but by virtue of just focusing on eliminating waste from the system, we were able to take that higher cost spend and drive it to a lower spend barrier, if you will. Specialty pharmacy is going to continue to grow, and it just becomes extremely important that that insurers and PBMs think differently about controlling other aspects of the spend around it while trying to really drive towards the most appropriate therapies versus a therapy.
Thank you. I got another question here. Could you describe a bit about the mergers and acquisitions in terms of example given here as CVS and others acquiring everything from the specialty to the benefits to the others, and what the impact of that will be on the evolution of both pharmacy and the delivery of healthcare going forward?
Yeah, it's a fantastic, fantastic question. And I'm thinking only because I think 2021 is going to be a bigger M&A year than we've seen in prior years as well. But there's a tremendous opportunity, right? I mean, you look at what CVS is doing with their health hubs, what CVS wants to do with the Minute Clinic. They're the opportunities in terms of really allowing people to perform, whether it's the RN in the Minute Clinic, whether it's the pharmacist behind the pharmacy counter. The opportunity to allow people to perform at the top of their license is phenomenal. What is going to need to change is the drivers of the misalignment. If a CVS or a Walgreens or any one of these guys pivots from worrying about, well, how much are they spending on those diapers and the 12 pack of soda, and if they start pivoting towards more of the healthcare part of it, you're going to see a healthcare consumer experience like never before. And we're seeing that. I think CVS is doing a lot of different things to get extremely creative. Village MD, which is a set of primary care. It's basically a primary care chain, if you will, across the country, is now starting to partner with Walgreens and starting to show up in certain Walgreens pharmacies across the country. But what gets me more excited is are the pockets of healthcare M&A that aren't getting as much press as one would think. So I'll give you another M&A example. Centene, which is one of the largest Medicaid players in the country, just bought Magellan's pharmacy business and Magellan's behavioral health business. We just talked about the fact that prescription drugs for mental health are the biggest driver of Medicaid spend, one of the biggest drivers. You got Centene just picking up a large behavioral health and a large pharmacy benefit manager and really saying, let me go at this very differently and see if I can crack the nut differently. I think we're going to see more innovation hopefully come out of some of these merger and acquisition activities over the course of 2021.
Thank you. And here's an interesting question I believe I've just got from one of our students. For acceptance of value-based medicine across the board, where do you think standards of reimbursement must begin? Who will be the price setter? And if the government, how much worry do we have that it becomes an infringement on the idea of capitalism?
Yeah, it's a fantastic question, right? I mean, I love it. It's extremely, extremely well worded. And I feel the notion of value needs to take on a broader perspective. And value-based medicine in this country, value-based healthcare in our country has become too much about the insurer holding the provider accountable. And that's where, folks say, well, are you really squeezing us the right way? Are you squeezing us the wrong way? Are we impacting capitalism? Let me take a non-healthcare example and talk about value for a second, right? We're all sitting at home. We've been sitting at home and doing stuff for the last, 8, 10 months, 12 months. Every single one of us in one way, shape, or form has padded Jeff Bezos's wallet, right? We're all Amazon Prime customers. What he is delivering is value. He says, I'm going to allow you to price shop online and pick the best price point. Once you price shop and you figure out the best product you want to buy, I will deliver it to you if you're a Prime customer within 48 hours. If you don't like the product, no questions asked, you can return it for free. And oh, by the way, if you want to talk to a customer service representative, I don't know if you guys have ever tried calling into an Amazon customer service line. They will literally call you back within 5 seconds. He has redefined value in retail, right? Did that kill capitalism? No. He basically said, I am going to redefine what people want in terms of the customer experience. So value-based medicine has become too much about holding providers accountable. So when, as an example, when we talk about value-based care and we talk about ourselves as a value-based PBM, we're finding that we can keep access wide open. We can allow folks to go and have their physician prescribe whatever makes sense. We are able to work with the physician and switch therapies. And this is our pharmacists, right? So our pharmacists, this is the power of being a pharmacist in the new world, right? Our pharmacists are having clinical consultations with physicians. They are connecting with physicians 88% of the time, switching therapies 64% of the time, and convincing the physician to have the patient go into the pharmacy and pick up a different medication. That is not curbing capitalism. What it is curbing is waste. It is giving the physician, if you ask a physician what they lack in their armor, they will tell you they lack depth in pharmacology. Putting the pharmacist alongside the physician and changing behaviors is absolutely in sync with capitalism. It doesn't take anything away from capitalism. It's basically saying, let's be capitalistic, but let's not waste. It's eliminating waste and being smart about healthcare.
Thank you. That's I think a great perspective. I think for, again, as our students are listening in, to see the impact that pharmacists are having currently in terms of all of the aspects of benefit here on all four of those quadrants of impact. And one other question regarding supply chain. The supply chain in terms of the impact of supply chain issues on distribution and other aspects of the managed care and the realm of prescription medications and other therapies. What do you see as the evolution of that, as we've seen a lot of this change even over the past year in terms of availability and pricing and other sorts of things and their impact?
I think it's a really interesting question. And I think and this is where some of the reimagining is going to have to happen. When you look at, here's what we felt as a country last April and May. From a supply chain standpoint, we were petrified. So healthcare organizations, pharmacy benefit managers, right? We were petrified across the board about the fact that we have an over-dependence on China and India as it pertains to generics. A very, very significant dependence. And as both those countries were in the midst of their own shutdowns, we were not sure what would happen to quite frankly, generic medications being available in the United States, right? What we are hopefully going to see is going to be two things. One, we are going to see more dispersing, if you will, of what that generic back office looks like. We're not going to see China and India be the only two places. We're going to see, I'm going to tell you, for example, in software, we see Ireland taking on a life of its own. We see, the Philippines taking on a life of their own in terms of the service model. So it is going to absolutely allow us to have a much broader, it's going to drive a much broader footprint, if you will, in terms of the supply chain. And then what we're also going to see is vaccines at large. I think we're going to see a demand for vaccines that we've never seen before. And that is going to force the world at large. If the world is flat, it is going to force the world to, and the United States especially, to really go back to the drawing board and figure out how, demand does not outperform supply. We're seeing that right now, right? We're seeing that with COVID vaccines. The demand far outweighs supply. We can't afford for that to happen. And I think we're going to see a lot of that change over the next 5 to 10 years.
Thank you very much. I think that actually is probably the time we have for questions. I will just say, and unfortunately, the one thing missing in a Zoom presentation is the ability for applause, but I will say that I'm sure that for feedback I've been getting, and actually just got one more question, so I'm going to ask it. Do you believe pharmacists getting national provider status will change how pharmacists are being used and deployed in healthcare?
I absolutely hope that happens. We're seeing the evolution of, we are going to see the evolution of a renewed understanding or embracing of the criticality of pharmacists in the healthcare ecosystem. Absolutely, I would not be surprised if that shows up in the next 2 to 3 years. That's the beauty of where we are right now. We don't have enough primary care physicians, right? When we hit the primary care physician bottleneck, even 5 years ago, people said, well, let's start getting RNs, registered nurses, ready to take on basic stuff. RNs took on a life of their own. In the minute you go to a minute clinic at a CVS, you don't find a PCP. You find an RN who can handle all of the basic PCP stuff, right? We are going to hopefully see pharmacists become more mainstream as it pertains to being a healthcare provider. We're going to see pharmacists deploy care at the top of their license behind the pharmacy counter. We're hopefully going to see pharmacists want to get excited about working at organizations like EmpiRx that want you to perform, that want you to be that preferred partner to a physician. 88% of the times our pharmacists reach out to a physician, they pick up the phone because they do not call the physician through the patient line. They're a PharmD calling the physician, looking to have a clinical conversation with a case summary in hand. That's healthcare. I think it is. I am so excited for every single one of you. You are so perfectly poised to be at exactly where you need to be as healthcare is evolving on our watch. So thank you for your time today, and congratulations to every single one of you for being at such an interesting juncture in healthcare.
Well, thank you very much. I think as all of us, I think would attest, I think that's a lot to be encouraged and excited about. And what I would only say from all of the feedback I'm even hearing in real time, just a wonderful, I think a wonderful opportunity to hear from you, a wonderful presentation, and one that was both engaging and I think very educational. I think it was fabulous, and I really am excited to certainly continue to hear more from you and from EmpiRx, and looking forward at all of the things that I think you are doing to really push forward both the evolution of healthcare, but also the evolution of pharmacy as well. So we're excited certainly to have you with us today. We thank you for your time. We thank you for the wonderful insights, and we look forward to hearing more from you. So thank you for your time, and thank you everyone for being here today. We appreciate it. And this now concludes our, what is that now? I believe our 9th annual Pieroni lecture. And we're thrilled to be able to celebrate that with the words we heard today. So thank you all for being here, and have a wonderful day.
Thank you. Take care. Bye-bye.